Okay, so this is the second video on homeostatic disorders. Okay, in the first video I talked about the physiology of homeostasis, the coagulation process. Okay, first thing I want to talk about is the developmental hemostasis. The factors 5, 8 and the platelets actually approach their normal levels during the second trimester. Okay, and you have to pay attention that premature babies are at increased risk of coagulatory disorders because some coagulatory factors are not yet mature, okay, or not yet normal at their normal levels. The procoagulants and the anticoagulant proteins attain their normal levels within or at 1 year. Okay, so this is why the premature babies at increased risk of coagulatory disorders. Okay, some procoagulant and anticoagulant proteins that the body attain their normal levels at 1 year, but the protein C normalize at the adolescent. So this is what I want to talk about in developmental hemostasis. Now let's start with the causes of bleeding. In the previous video I told you that to have a normal coagulatory process or normal hemostasis, we have to have normal blood vessels that constrict with the bleeding, normal platelet count and function, and normal coagulatory and procoagulatory process. Okay, so if we have a problem with the blood vessels or with the platelets or with the coagulatory factors, then we will have a hemostatic disorders. Okay, so the causes of bleeding are divided into two groups: the hematological causes and the vascular or non-hematological causes. The vascular causes due to anything that may irritate the vessels, okay, like child abuse, for example. If we have vasculitis, okay, tumors of the blood vessels, the presence of polyp, varices, okay, varicose veins, the ulcers, any other trauma, okay. If we have a condition that called angiodysplasia or telangiectasia of the blood vessels, or Ehlers-Danlos syndrome, okay, or anything that irritate the blood vessels may cause bleeding. Okay, again, any trauma, any tumor, any infection, any syndrome like Ehlers-Danlos syndrome, any dilation of the blood vessels, any ulcer, telangiectasia or angiodysplasia, they all may cause bleeding. Okay, so this is the vascular or the non-hematological causes of bleeding. We have also the hematological causes of bleeding. The hematological causes of bleeding are subdivided into the platelet causes and coagulopathy. You know that to have coagulation you have to have good platelets and good coagulation factors. So any problem with any one of them may cause to bleeding disorder. Okay, so the first thing I'm going to talk about is the platelets disorders. We have disorders of platelet numbers. Okay, the normal number of platelets should be between 50,000 okay and 400,000. If we have below 50, then we may have a platelet disorder. Okay, and the function of the platelets may be interrupted. Okay, I'm going to talk about the disorders of the platelet function. In this video I'm going to talk about specifically the platelet number disorders. Okay, the platelet numbers may be reduced due to one of these three causes. It may be due to decreased production of the platelets. You know that platelets are produced in the bone marrow. If we have a case of decreased production in the bone marrow due to any cause, it will reduce the platelet number, or due to increased destruction of the platelet. It may be produced normally in the bone marrow, but we have an increased number of destruction of these platelets. This will lead also to decrease in platelet number. Okay, so the second cause is the increased destruction or the sequestration of platelets in the spleen. Let's start with the decreased production of the platelet. The platelet production in the bone marrow may be interrupted by congenital problem or by acquired problem. Okay, so it may be interrupted from birth or since birth or after some years of life. Okay, so let's start with the congenital causes of platelet decrease production. The logic says that if we have a problem with bone marrow cells that produce platelets, then we have decreased number of platelets. The cells that produce platelets in the bone marrow are megakaryocytes. Okay, and we rarely see decrease in platelet production in the bone marrow apart from aplastic syndrome. Usually we have a syndrome. Okay, one of its elements is decreased platelet production. Okay, like for example thrombocytopenia with absent redi. Okay, thrombocytopenia with absent redi. In this syndrome we have a thrombocytopenia plus orthopedic abnormalities. Absent redi is the absence of the radius of the arm. Okay, so this disease is signified by the thrombocytopenia plus orthopedic abnormalities. Like what? Like abnormalities especially of the upper extremities. Okay, the thrombocytopenia in this syndrome, the absent radi syndrome, okay, usually improves with time. Okay, so this is the first thing, to have thrombocytopenia in a context of other disease, and this is the most common. But also we still may have a case of a megakaryocyte. Okay, a megakaryocytic thrombocytopenia means the decrease or the absence of megakaryocytes without underlying syndrome or other no other congenital anomalies. The only pathology we have is the absence or decrease in megakaryocytes. Okay, so these are the congenital causes that may underlie thrombocytopenia. Also we have in decreased production, it may be acquired. Okay, some event may happen that lead to thrombocytopenia. Okay, and also in this case it more happens in context of pancytopenia as a result of bone marrow failure. So the baby born with a normal bone marrow, okay, but after some time we have a bone marrow failure, so we have a pancytopenia, and one of the elements of the pancytopenia is a thrombocytopenia. What may cause the bone marrow failure, okay, after time? It may be caused by infiltrative or aplastic process. Like what? Like chemotherapy. Okay, chemotherapy may affect the bone marrow and kill the platelets, or the megakaryocyte, causing pancytopenia and thrombocytopenia. Cyanotic congenital heart disease. Also infections. Actually infections very important to cause the acquired thrombocytopenia. Like what? Like torch infection, you know, toxoplasmosis, others, rubella, and so on. Okay, HIV, Epstein-Barr virus, measles, remember them well. They are all causes of thrombocytopenia. HIV, Epstein-Barr virus, measles, other viral infections. Okay, also drug. You can count chemotherapy as drug. Okay, drugs like anticonvulsants, okay, antibiotics and cytotoxic agents and heparin, okay, remember anticonvulsant, antibiotics, cytotoxic agents, and of course the huge heparin, okay, they all are causes of infiltrative destruction of the bone marrow that will lead to thrombocytopenia. So remember, we are talking about decreased production. I told you that we have congenital decreased production and acquired decreased production. Congenital since birth is due to usually the presence of a syndrome that resemble thrombocytopenia, okay, like absence redi. The acquired is due to bone marrow failure after some time of birth, okay, due to the drug or viral infection or chemotherapy, cyanotic congenital heart disease, and so on, okay. The drugs like antibiotics, anticonvulsant, cytotoxic drugs, and heparin. These are the diseases of the production of the platelet. Okay, please watch this video.
Blood cells are produced in the bone marrow. The three main components of blood are red blood cells, which carry oxygen, white blood cells, or leukocytes, which fight infection, and platelets, also called thrombocytes, which assist in the formation of blood clots. When a blood vessel is damaged, platelets adhere to the surface of the damaged vessel and release chemicals. These chemicals attract more platelets as well as red blood cells in order to form a clot or thrombus. As the clot grows, the blood vessel narrows, thereby decreasing blood loss. This process is called coagulation. Normal platelet counts are in the range of 150,000 to 350,000 platelets per microliter. Thrombocytopenia is a disorder in which there are not enough platelets. When the platelet count is decreased, the body is unable to form blood clots and therefore is unable to control bleeding. Bruising and bleeding can occur from relatively little trauma. When the platelet count gets below 10,000 platelets per microliter, bleeding can develop without trauma. Chemotherapy-induced thrombocytopenia is a disorder that develops as an adverse effect of chemotherapy. Cancer drugs not only kill cancer cells, they can also damage the platelet-forming cells in the bone marrow. The severity of this disorder depends on the type of chemotherapy and the duration of treatment. Fortunately, chemotherapy-induced thrombocytopenia can be managed with platelet transfusions, additional medications such as blood cell growth factors, or with blood stem cell transplants.
So this is all about the production of platelets. What about if the platelets that are produced were not able to survive? There's something that destruct, okay, these cells. The destruction of platelets may be immune mediated, okay, by immune mediated mechanism, and this is the most common cause of destruction induced, okay, idiopathic thrombocytopenic purpura. I'm going to talk about that. Maybe due to some syndromes like Wiskott-Aldrich syndrome or due to a thrombotic micrognathy. I'm going to talk about them in the subsequent video. Okay, in this video I'm going to talk about the immune mediated mechanisms. Okay, the idea about the immune mediated mechanisms of a platelet destruction is the happening of rapid peripheral destruction, okay, by the spleen of antibody coated platelets. Okay, so let's assume this is a platelet, okay, and due to any cause, I'm going to talk about them now, we have antibody coated antibody. The blue thing here is the antibodies, okay, antibody coated a platelet. What really happened is the reticular endothelial cells in the spleen, these are the cells that are prepared to phagocyte any abnormal cells, okay, will phagocyte the platelets that are coated by the antibodies, and this will reduce the number of platelets. This is the idea about the autoimmune or the immune mediated mechanisms of the platelet destruction. Okay, we have many diseases of that. One of them, according to the age, is neonatal alloimmune thrombocytopenic purpura, and the other one is the idiopathic thrombocytopenic purpura. Let's start with the neonatal alloimmune thrombocytopenic purpura. What really happens is there is sensitization of the mother to antigen on the fetus platelets. Okay, so by anyway the baby blood mixed with the mother blood, okay, and the mother blood is sensitized to the baby platelets, okay, to the baby, okay, let's platelets. So this is the baby platelets, this is the mother blood. Due to any cause, the mother blood is sensitized to baby platelets, so the mother produces antibodies. These antibodies go to the baby platelets and coat them, so they are now coated platelet coated antibody. Okay, so the mother produces antibodies that cross the placenta and attack the fetus platelets. What happens that the antibody coated platelets are sequestered by the reticuloendothelial cells in the spleen, as I told you. Sometimes the baby or the fetus blood must not mix with the mother blood to make the sensitization. Sometimes the mother is already sensitized due to the presence of idiopathic thrombocytopenic purpura in the mother blood, okay, or history of this disease, okay, so she already has the antibodies without any mixing between the mother and the fetus blood. So she already has the antibodies, and antibodies cross the placenta, coat the platelets, and the platelets are sequestered by the spleen, reticuloendothelial cells. Okay, so the clinical manifestations of the neonatal alloimmune thrombocytopenic purpura is mainly the risk of intracranial hemorrhage. So they have less platelets, they are more liable to any bleeding, so risk for intracranial hemorrhage is very significant and important. And this intracranial hemorrhage may happen in utero or and during the delivery, okay, during the delivery process, due to the molding that happens during the delivery. Okay, and the greatest risk of the bleeding is not in utero but during the passage from the birth canal. Why? Because we have a molding and the liability for intracranial hemorrhage. Okay, if we suspect the intracranial hemorrhage, so we have to fetus, scalp and percutaneous umbilical blood, and we have to sample this blood to know the platelet count. How to treat this condition? If we have neonatal alloimmune thrombocytopenic purpura, we can treat it with corticosteroid and IVIG. Okay, oops, I'm sorry, I mean cesarean section. The treatment of this condition is the treatment in utero and after birth. Okay, in utero you have to give IVIG, okay, and you have to deliver the baby by cesarean section because the normal vaginal delivery is associated with higher risk. Okay, after delivery, the neonates with less than 20,000 per micrometer platelets, you have to give IVIG or corticosteroids for or both of them until remission of the disease. Okay, and if the case is more severe and you see it is very severe, you can give watch maternal platelets. Okay, you can give watch maternal platelets. So this is how to treat alloimmune thrombocytopenic purpura during pregnancy and after birth. Okay, now let's move to the other condition, the idiopathic thrombocytopenic purpura. Actually, they are very, very similar. Okay, some differences in the time of happening of the disease and so on. Okay, so what happened an idiopathic thrombocytopenic purpura that after an acute viral infection we have IgG and IgM antibodies. Okay, so these antibodies after a viral infection attacks the platelets and again bind to its membrane and coat the platelets. Okay, and again here we have platelets that are coated with the antibodies. Okay, in the spleen, so this is the spleen, we have the reticuloendocytes, the FC receptors of the reticuloendocyte will catch up the this platelet and sequester it. Okay, so we will have destruction of the platelets and the thrombocytopenia. Really, it's presented as symptom for autoimmune disease like SLE. Okay, the thrombocytopenia or idiopathic thrombocytopenia sometimes is a symptom or the first presentation of diseases like SLE, but this is rarely happen. Okay, so the clinical manifestations of idiopathic thrombocytopenia slightly differ from the clinical manifestation of neonatal thrombocytopenic purpura, because in the neonatal the danger is to have intracranial hemorrhage because the stress of pregnancy and birthing. Okay, but the clinical manifestation of idiopathic thrombocytopenic purpura is that we have viral infection 1 to 4 weeks prior to the idiopathic thrombocytopenic purpura, and then we have abrupt petechiae, okay, or purpura and or epistaxis. These are skin lesions. The petechiae are non-blanchable, okay, skin lesion with below than 2 millimeters diameter. Okay, the purpura are adjoint petechiae together. We have here petechiae, them together we have a purpura. Epistaxis bleeding from the nose. Okay, so how to diagnose idiopathic thrombocytopenic purpura? Actually, clinical manifestations, blood the platelet count. Okay, if it is low, it's enough to diagnose idiopathic thrombocytopenic purpura. There is no need to do I'm sorry, there is no need to do a bone marrow examination. Okay, but if we have atypical presentation of the disease, then we can do bone marrow examination to rule out other infiltrative disorders like what? Like leukemia. Leukemia is a cause of thrombocytopenia, as you know. If we have atypical presentation, so we have to suspect leukemia or aplastic anemia. Okay, so we have to do the bone marrow examination. In idiopathic thrombocytopenic purpura, the bone marrow examination reveals an increase in megakaryocytes. Why do we have increase in megakaryocytes? Because the bone marrow will try to compensate the thrombocytopenia by increasing the number of megakaryocytes. So it's due to severe thrombocytopenia. But the erythroid and the myeloid elements will be normal in idiopathic thrombocytopenic purpura. Okay, in leukemia and aplastic anemia, we have some problems with the erythroid and myeloid. So how this is how we differentiate between them all. Okay, the treatment of idiopathic thrombocytopenic purpura depends in the first place on the platelet count. Okay, if we have a very low number of platelets like below 30,000 per micrometer, then we have a method of treatment. If we have above 30,000, usually therapy is seldom indicated. Okay, it's very important to treat if we have above 30,000 millimeter. Okay, it usually doesn't need to treat unless we have a clinical indication for that. If we have below 30,000, then we have moderate to severe thrombocytopenia. Okay, the severe thrombocytopenia is below 10,000. Okay, then we have to treat. Okay, below 30,000 we have always to treat. Okay, below 10,000 is a severe thrombocytopenia. How to treat? We can give prednisone. Okay, this is a steroid to treat the condition. For 2 weeks we give 2 to 4 milligram per kg per 24 hours, or we can give IVIG. IV immunoglobulin 1 gram. Notice that the dose of IVIG is 1 gram, the dose of prednisone is less, 2 to 4 milligram per kg per 24 hours. The IVIG is just given for 1 to 2 days. The prednisone is given to 2 weeks. Okay. The act of them is to decrease platelet clearance. So they have nothing to do with antibodies number. Okay, they just decrease the platelet clearance, and this is how they work. If we have acute and life-threatening condition, okay, moderate and severe cases we treat with prednisone and IVIG. If we have acute and life-threatening condition, we treat with splenectomy plus giving some drugs. Okay. So splenectomy is the final treatment if we have very life-threatening condition. The prognosis of idiopathic thrombocytopenic purpura is pretty good. 80% of cases will resolve within 6 months. The rest of cases will have chronic, or they are called chronic idiopathic thrombocytopenic purpura, and you should treat with repeated IVIG, IV anti-D, and high dose of steroids. So now we have 3 drugs. If we have a chronic idiopathic thrombocytopenic purpura, IVIG, steroids, and the anti-D. Okay, we are giving them repeatedly to delay the need for splenectomy. The chronic idiopathic thrombocytopenic purpura will definitely need splenectomy at one time of the at the time of their life. Okay, but to delay the need of splenectomy, we give these IVIG, the steroids, and the anti-D. Okay, and you have always to rule out other causes, secondary causes of idiopathic thrombocytopenic purpura and chronic cases like SLE and HIV infection. You have also to weigh between the risk of splenectomy is a surgery, and the surgery have risk, may cause sepsis and pulmonary hypertension. So you have to think to weigh between the risk of splenectomy and the risk of the idiopathic thrombocytopenic purpura. So this is all about the production and destruction and sequestration platelet problem. Okay, and the next video I'm going to complete the talk about the platelet disorders that will cause the hemostatic disorder. Thank you very much. Before I finish, I want to show you this video.
Immune thrombocytopenic purpura is an autoimmune disease in which the body attacks and destroys its own blood platelets. Platelet destruction often causes chronic bleeding, bruising, and fatigue. With R788, Rigel is investigating methods to negate the autoimmune process and platelet destruction. Here's how it works. Blood platelets are sticky cells produced in great quantity by the bone marrow. Their purpose is to gather at wound sites to promote blood clotting and healing. ITP patients have antiplatelet antibodies and experience high percentage drops in blood platelet counts. But how does this happen? It's believed that once the antibodies attach to the healthy platelets in the bloodstream, they flow through the liver and spleen. Within these organ tissues are macrophages, or immune cells, with receptors that recognize the antiplatelet antibodies. Grab hold of them and their platelet cargo. When the antibody-coated platelets attach to the Fc receptor of the immune cell, they activate the enzyme SYK, a master regulator within the cell. SYK triggers the immune cell to engulf the attached antibody and platelet. Destruction follows. The result, lower platelet counts and a susceptibility to chronic bruising, bleeding, and fatigue. Our product candidate